Good evening, everyone, and I hope that this webinar finds all healthy. So it's been about a month since most of our practices have been operating under the moratorium of non-urgent surgery because of the coronavirus pandemic, and it's placed a tremendous stress on our practices and indeed all of medicine, both clinically and financially. So our patients and partners, employees are having to learn to live with this virus. And this webinar is part of AANA's effort to make sure that our members and their practices survive and then thrive in the future once again. Our first webinar outlined how practices initially responded to the crisis, and now we'll discuss the current state of practice and how we're planning to or already have begun to ramp back up, making sure that we keep the health and safety of our patients, our staff, and our facilities at the forefront of all our efforts. We're blessed and lucky tonight to have a distinguished panel of AANA leaders from a diverse geographic and practice setting environment. Our goal is to relay practical practice management information and experience. But please remember that there are many ways to manage this crisis, and the way that you manage it at home in your own situation is going to be specific to you. Our opinions here are our own and not specifically endorsed by AANA, and indeed, this is, as we said in the ramp up to this, it's a level 28 evidence. We are learning a tremendous amount from each other, and just talking before with everyone, this is a learning experience for all. So we're lucky tonight to have with us Brian Cole of Midwest Orthopaedics at Rush. He's the first vice president of AANA. Mark Gettleman of the Southern California Orthopedic Institute. He's the second VP of AANA. Jim Stone at the Wisconsin, who's the treasurer of AANA. Eric Stiefel of Valdosta Orthopedic Associates. He's the advocacy chair. And Nick Scaglione, who's the chair and senior VP of the orthopedic service line at Northwell Health in New York City, which is unfortunately ground zero of this pandemic. He's the current chair of our AANA Education Foundation and Journal Board of Trustees, and he's a past president of AANA. So each of our faculty will outline where they are now and how they're planning to ramp up as this pandemic hopefully recedes a bit. So please make sure your phones and audio and visual are muted, and use the chat graphic to ask any questions. We'll get to them. The webinar will be posted on the website, and there are several helpful links there also to good information. So without further ado, I'd like to thank AANA staff, Kim Santinello, Matt McNutt, Adam Foltz, and Robert Kaika for putting this together. And now on to Brian Cole, who's going to tell us what's going on in the Windy City. Brian.
Thank you very much. So good evening. Very clearly, webinars like this allow us to share ideas, but as Lou pointed out, keep in mind that your local environment, the disease burden, the legislative and the regulatory positions will largely determine how we practice today and what we can actually do tomorrow. So I guess my disclaimer is that what we may or may not do in Chicago as a private academic practice that partners with a COVID medical center like Rush, where we also have independent ASCs, may not be exactly generalizable to what you have in your local environment. I think the other overtone tonight is that I think it'd be very helpful to think about what it's like to live with COVID rather than life after COVID, because we all now recognize that the behaviors and patterns of our practice today are probably going to exist with us for the foreseeable future. So here we are providing an update. I'm going to give a brief update of where we are 2 weeks after our last webinar. I'd like to provide some the specific decision-making principles that all of us are contemplating as we emerge and navigate between emergent and elective surgery, as well as office care as part of what we would consider essential. I know this narrative is occurring at a time where there are ongoing restrictions locally to elective surgery in some hospitals. As recent as an hour and a half ago, Chicago announced that elective surgery will be allowed after May 1st. I'll also make some points about where we are for educational purposes in the SBA program and how we're managing this. So Kim, if you can move to my first slide. So this is sort of the economic overview that if you can go back one, please. Thank you. This is the economic overview, and I think I think about it in three phases. One is the white elephant phase, and two is, you putting our finger in the drain while the faucet is off. And 3 is emerging with sort of a shiny new home, but one that's scaled down. 6 weeks ago, when the disease burden in the U.S. began to increase, we limited surgical treatment to the highest risk patients that had urgent or worse problems. And we said, look, anyone who can be treated or neglected or with skillful neglect for 4 to 6 weeks and wasn't made worse, those are people we can put off. But then 1 week later, on March 18th, in an effort to protect the hospital systems from overload, as well as protect our frontline workers, to make sure there was enough resources, we were mandated to eliminate non-essential services, and that included elective surgery. So within 10 days of stopping elective surgery, and I just want to tell you what we did in a response from our webinar just 2 weeks ago, we successfully but painfully furloughed approximately 75% of our entire business line. And then we weighed that against close to 0 charges in April and May, and 50% charges maybe for June and August, with an overall assumption that in 2020, we're going to be no better than 70% of 2019. So furloughing about 75% of our staff while providing benefits. We shrunk our business to accommodate urgent care. We deferred, abated, and renegotiated virtually every line item, including rent, premium, taxes, vendors, supplies, and every one of our partners agreed to forego a paycheck for the next 3 months. We had to manage our employed physicians with some very difficult decisions, and pertaining to our government programs, received our portion of the CARES Act Medicare payment related to CMS provided in 2019. We received our advance on CMS for future services, and we received our PPP loan within hours of being assigned our loan number. We're not going to go into great detail there, but I want you to understand that the PPP loan is not essentially a free lunch. It was provided in general to maximize forgiveness, but you got to meet lots of tests. And essentially, you'll learn about this and speak to your local experts on this, but the first one is you got to spend 75% on your payroll-related costs, and that's your wages, healthcare, and 401k over the 8 weeks. And remember that your loan was calculated on all employees that were making up to $100,000. The main test, though, that will allow you to determine forgiveness will be by you achieving the highest FTE count relative to the baseline period that loan was calculated. So if you don't give, and that's actually based on 30 hours. So if you don't give them enough hours, you're not even going to be able to pull them off unemployment because the unemployment benefits are. I just want you to, I think the take home that we learned is that continue your business practices as if this loan didn't exist. And if you have physicians who have direct expenses that are going to be credited for this loan, keep in mind that there are lots of strategies, but the current strategy is by April 27th to June 27th, you want to ramp up to get that FTE count if your goal is to maximize forgiveness. And that may be a time, based upon how you plan to reemerge, where you actually might want to consider exhausting their PTO at the same time. So one strategy is you bring them back for 30 hours, then they are actually a full FTE, and then you can actually ramp out or utilize their PTO, and that will help you on the wage test. So pay attention to the details there. So phase 2, which is this sort of put your finger in the drain, and that's the most initially troublesome part now that we're dealing with, is that we had to reduce this overhead burden. We have this white elephant that was built for 100%, but now we have to reduce everything to basically stop the hemorrhage at a time where we have no running water. And that's really where the urgent model that all of us are existing in, that's what we're going to talk about, how you navigate that. I'll review how you kind of plan. You can plan for that at this time, where you may actually have this concept where elective care can't really be provided for the next couple of weeks. And then finally, I just want you to think hard about this business model, that when we all emerge with this shiny new home with 1-car garage that's perfectly manicured outside, we may be living in a market for the time being that's about 30 to 40% contracted. And that's at a time where the efficiencies that we're used to experiencing will be substantially reduced just because we have to continue to social distance. So when things open up, that doesn't mean we're eliminated from the burden of being socially responsible and continue social distancing. So we're hoping we can all rebuild with a leaner overhead model, enhanced efficiencies, greater yields in our professional service lines, and ancillaries that will drive benefit from consolidation. Now I just want to finish up with going over this narrative and how you might navigate between the lines. Next slide, please. I think the most confusing thing that we're seeing is this split between what's essential and non-essential. And again, the whole purpose was to provide, to eliminate non-essential things so the hospital system would not be overwhelmed. And that left us with the easiest thing, and that's emergent care, life or limb. It's somewhat ironic that what was also considered to be essential was the fact that you can still order and pick up a pizza, but you can't take care of pain and suffering. And that's the hardest narrative that we're having right now. So I'm going to focus on what we're doing to sort of manage the splitting the difference of what's non-emergent, but that may be time sensitive and associated with some of the intangibles. So if you go to the next slide. Remember, the initial mandate was by the federal government to eliminate essential services, including elective surgery, in a fashion that would speak to preventing overload. But the real question was, why is pain and function and inability to work not part of the same narrative? Next slide. So where we basically went to is we started to look at procedures and policies that were short of emergent. And the easy ones are the conditions that fail to respond to non-surgical care, or conditions that without treatment could result in compromised outcomes. The hard ones are the conditions that have intolerable pain, especially when narcotics might be required, or those who have sustained functional losses that preclude them to return to even activities they're living, or even potentially more challenging is significant financial hardship. Next slide. So we entertained several considerations, and many of these you have seen and read about. I just want to give you an outline, and you should know that this article, the substance of this content, will be published in ASMAR, the open access journal for arthroscopy, will be published within the next 24 hours, so you can get access to all of this and use it for your own institutions. But clearly the hospital and inpatient, a lot of the current guidelines are hospital and inpatient concerns. So what I'm largely speaking to are the things in the ambulatory surgery center. Nick Scaglione is going to speak at great depth of what's happening on the inpatient side as well, but there's a lot of overlap. So certainly the considerations have been locations where the outbreak has most likely peaked, where there's a low burden of disease in the facility and the system, and where there's ample resources locally in the things that you see here. And as far as how things are going to come online, it's largely going to be the independent ASC, then the hospital-based ASC, then the community hospital, which has a lower burden for the COVID crisis, and then finally the academic and the COVID hospitals. Next slide. With respect to the patient, where we are now is we are looking at patients who are healthy, less than 65, ASA 1 or 2, and if you're beyond that age or beyond ASA 1 or 2, we utilize a medical director. There has to be no influenza-like symptoms like you're seeing here, and we take the history that all of you are probably doing now for urgent care, which is recent travel, if they have a sick family member, prolonged exposure to COVID-19 patients. Next slide. We have one entrance in and out of the facility. When the patients walk in, they, and this is for staff as well, hand disinfection, we take their temperature, we take their history, we give them a mask, we give them a wristband to say that they've gone through that. They then, in our ambulatory setting, go for point of care testing, and we're going to talk about that. They also sign a COVID-19 specific consent form, and they are present with no one else. The others are either waiting in the car in the garage or potentially one family member if it's a minor. Next slide. With the staff, the great news is that despite all the things we're talking about, we now know in the healthcare setting that these are the measures that work. Proper training and retraining of our staff. They undergo the same screening. Point of care testing should not be a surrogate for enter or exit. We're going to talk about that. Hand hygiene and not touching your face are probably two of the most important things, as well as minimizing contact with a patient without a mask within 6 feet. And if you have to have physical contact, minimizing the duration of that contact. When it comes to intubation, that's done with minimum staff in the room, just what's required. They are all wearing N95s. They're using a Mayo stand with a plastic cover, basically, which is a makeshift screen that protects them caudally and proximally. And we have certain procedures regarding delays between room entrance and cleaning the room, and that's modified with point of care testing. Next slide. The other factors that we're using are case prioritization based on the local environment. All of our cases are reviewed by a board. We make sure that we are using efficient surgical times and procedures. For example, in the surgery center where we use overlapping surgery in terms of non-critical components, but not overlapping procedures, we essentially allow 6 cases if they're larger cases per surgeon, or 8 cases if they're smaller cases, that being less than 1 hour each. We have expedited post-operative recovery and discharge procedures. And we have basically looked at these other variables. I want to just talk about these 2 last things and let the others have their opportunity to speak. One of the things you'll see from the American College of Surgeons is a consideration for sustained reduction in cases for 14 days. that proposition is challenging because that may be embodied in the availability of testing for the disease. So if we're truly testing people who are symptomatic, that's a burden that is entirely relevant. But if we're testing more comers in the equation, then that burden is actually probably excessive in this equation because it's mainly a function of testing and not of disease burden. With respect to point of care testing, I think the take home is the following. Clearly, it's an incremental step in the right direction, but it should not be looked at as a solution in and of itself. It teaches a lot about prevalence. It makes us feel safer in delivering care, but it really doesn't provide us the luxury to behave differently at this time, despite having a negative test. And that's true of antibody testing. The problem with antibody testing is that this is still a low prevalent disease, 2 to 3% in the entire population. So there's the challenges in that setting. There still is up to a 30% false positive rate. So if you're negative serologically, you know you haven't been exposed, but you're positive, you still may have been exposed, and you do not know if you can actually be reinfected. So the bottom line is we cannot get complete security from either the swab test or for being positive or negative from the blood test to see if we've been previously infected. And it's really universal precautions, assuming everyone might or could be positive, that should guide your behavior in the ambulatory setting. Next slide. So the other thing that we're carefully documenting is the availability of postoperative management, because that's clearly part of the process. It's not just doing the surgery, but you really need to have local resources to address postoperative care, including the potential for complications. Next slide. And finally, I'll just give you the examples of what we do for documentation. In the surgical schedule, we actually list the reason that we're doing the surgical. So in this case, functional loss that precludes return to activities. It might be intolerable pain. It might be the inability to have an occupation. And then in every case, we dictate all the reasons why that patient is undergoing surgery. This may provide cover. We're not necessarily concerned about the legal issue. I will tell you that unfortunately or fortunately, what's largely guided a lot of our behavior are the optics in your system. And that's something that really has to be taken into consideration, and that may weigh more or less heavily depending upon your local environment. So I'll leave you with that, and let's I'm interested to hear what the other speakers have to say, and we're going to have time for questions when this is all over. Thank you very much for your attention, and I wish you safety.
Thank you very much, Brian, for giving a lot of information in a short period of time there. Next on to Mark Gettleman, who had a social distancing birthday last weekend out in California. He's going to tell us what's going on in SCOE.
Thanks, Lou. Thanks, Brian, and all the other panelists. And obviously, I want to thank our team for putting this together. You know, California has been a different place than what I see on the news each night when I watch what's going on the East Coast. And certainly we'll hear from Nick at Ground Zero, and we're kind of on the other extreme. I'm in a private practice group. I have 40 physicians, and we are in affiliation with UCLA Health. And so we do have the opportunity to kind of see what UCLA is doing, and we work in conjunction with them. Unlike Brian, we didn't furlough our employees. So we've kept all our employees, trying to reduce only ones that were kind of in their training period where we didn't feel we can train them. And we've really tried to keep as many people as possible. We did, however, obviously have to reduce their hours. And so we've reduced ourselves to a 6-hour day for most of our centers in the clinic, where we are here for 6 hours a day, where we'll do some telemedicine and obviously some urgent emergent patients, those that need to still come in and be seen. One of the things that we felt was very important was for us to do our part to help keep our patients out of the emergency departments, out of urgent care centers, and out of their primary care doctors. And if we reduced our hours and our time too much, then it was going to force our patients into more higher risk environments. And so it was really important for us to keep our offices open, despite the fact that, as Brian said, our numbers are down 60+% in terms of what we're doing. We did get a similar CMS advancement, which was very helpful. And on day one, when we heard about the PPP, we were ready to go. We had all our ducks in a row. We had our paperwork ready to go. As soon as things happened, what happened here in California, I can tell you, our bank specifically was a bit overwhelmed. And they opened their site, and it took 5 days for them to get their site up and running to a point where we would even be able to start the submission process. And I think that few day delay was a real problem for us. And so consequently, with the first round of funding, we were not successful in gaining a PPP loan. What I did here since then is obviously the distribution of the PPP has been documented. Those of you in the Great Lakes area in the Midwest seem to got the largest percentage of PPP dollars based on population. California, we understand, was underrepresented in terms of the PPP dollars. And so we have not gotten that funding, which is obviously an important hope for us as we continue to look forward as we move forward. That said, when we look at our surgery centers are independent from the hospital. And so we have tried to do the same thing. Urgent and emergent cases only. Obviously, what that meant to was a fracture that couldn't wait, an infection, or something, acute tendon disruption or tendon tear or laceration. We also had a group of physicians reviewing those cases. And in our center, in our main office, which is a 6-room center, which was running, full bore, we cut that down to 2 rooms, only 2 days a week. So open on Tuesdays and Fridays only. And again, trying to minimize those patients. Governor Newsom yesterday announced during his lunchtime press release that elective surgery is an important thing that has to be reconsidered. And I know the California Orthopaedic Association and others have been helping lobby this. And as of yesterday, the governor has said that we can start to ramp this up. That said, we're now looking to how we do that effectively and safely. And so patient selection is going to be a big part of that. We're working on understanding testing and what's available. As we're seeing in California, the number of tests have been limited for a period of time. Now in California, if you want a test, you can get a test. So I think we're in an opportunity where more testing will be available. I think Mayor Garcetti and Governor Newsom, did get ahead of this. We were the first large urban area to go on safer at home. And I think what we've seen is our curve has stayed flatter all along. Now, does that mean we're just delayed and we're going to have a later spike? We honestly don't know. But I will tell you, on the press conference by the mayor every day and the governor every day, they're doing a very good job at, really emphasizes the importance of continuing to be safer at home. So what we are planning to do looking next week is we're starting to look at the backlog and the patients that, Brian has spoken to. These patients who do have significant financial hardship. And so our plan is to open up to running up to 3 rooms of our 6-room center, only 4 days per week with the same limited number of cases, and being able to use the other room to allow that aerosolization or viral load to potentially go down. So they can extubate in one room. We can then go into the other room, give it the time so that the staff can get in and clean the room in a safe environment. Financial hardship, I think, is something that does have to be looked at. If you look at California and my area, the motion picture and the television industry is completely shut down. I have an enormous number of patients who are involved in that, whether they're a grip or a lighting technician, a set director, a studio technician, all these people who are now out of work, who really need their surgical procedures done, are in a situation where not only are they not working, but they're not going to be ready to go back to work when the work comes back on board because of their ongoing symptoms. So I think it is an important thing that has been made by, our leadership here, both in the healthcare positions as well as the mayor and the governor. And I think we're in a place where we're hopefully going to ramp up. And personally, I hope that when we push the button for our PPP application, whether it's tomorrow or Monday, that we prove to be successful. So that's our take out here on the West Coast. And with that, I'll turn it back over to Lou and happy to answer any other questions.
Thanks, Mark. Just a reminder to anybody, if you want to ask any questions, you hit the chat button, which is the right in the middle, and write a question so we can answer those afterwards. Next on to Jim Stone in Milwaukee, who took all those PPP dollars from Mark out there in California.
Yeah, do you think it has anything to do with Wisconsin voting, Lou? So thank you very much for having me.
Never say that.
Yeah. I appreciate the opportunity to be here. I'm going to go through what we've done in our practice and how we're approaching surgery going forward. Just to summarize, in mid-March, just like everybody else, we made the decision to stop elective surgeries and limit office visits to only the crucial ones: post-ops emergencies, completion of care for injection series, and operative complications. And we kind of like Mark made the decision, which I think some of our business savvy friends may think is not the smartest, but we made the decision to keep staff on. So starting from mid-March, we decided, first of all, to pay all of our staff through the end of March until the government plans were all clarified, to give them that security, and then to make a decision going forward after April 1st. When the PPP plan was announced, along with a stimulus payment plan, our decision was to keep everybody on with no layoffs also, in anticipation of receiving a stimulus grant and potentially forgivable loan. We did have a concern. Again, our PACE rates are not as high in the Midwest here as some other parts of the country. And we were actually concerned to a certain extent that if we put people on unemployment, the benefits could be so great that they would have little incentive to come back to work. And we wanted to keep our people working and available for work once we could get going again. So from a cash flow strategies point of view, we figured that we would use our accounts receivable to meet our cash needs until April 1st, so one pay period. And then basically what we did, we received a stimulus check on April 10th, and that stimulus check was sufficient to cover payroll for the first pay period in April. We applied for the PPP on the first day it was allowed, which was a Friday. It got approved on Tuesday, and the funds were received just yesterday, 4/22, which was actually kind of fortuitous because the day your 8-week period starts is the day you receive your funds. So that will work out perfectly for us with regard to our pay periods, and we're going to utilize this cash to support the payroll and other covered expenses for the next 8 weeks. And hopefully, if things go right, we have retained all our FTEs, we should be able to spend 75% of that money on covered expenses and have that forgiven. That certainly is the hope. We have also applied for and granted the CMS advance. That was on April 20th. And another important thing I think for everybody to consider is we've increased our line of credit just in case, as we model things out going forward into the next few months, we end up needing to tap the line of credit. We also have decreased physician salary, and we've modeled our cash flows with what I think are reasonably conservative assumptions of starting activity in the office and in surgery June 1st and increasing it by 25% each month, with activity getting to 100% in September. But I fully agree with Brian Cole in that I think we have to start thinking about living with a new normal, where this is COVID for us is going to be a chronic disease. It's not an acute disease. So it's going to change the way we practice well into next year because of things like social distancing and things that need to be maintained, which will make ourselves much less efficient both in the office and the operating room. So I don't know if we'll get to 75% or 85%, but it's not going to be 100% in either setting. So we anticipate for sure a revenue cycle disruption through the end of the year. Our office practice is gearing up. We started during. Hello? I'm hearing something in the background. So we initially limited each of our physicians to a half day in the office per week. We're increasing that now starting next week to 2 half days in the office. All patients are being screened with all the stuff you just heard by history and temperature screening, and patients and staff are all wearing masks of some type, not necessarily surgical masks. We are also using telemedicine as much as possible. So no employees are on furlough, and the only problem we've run into is the occasional employee who, on being called in, all of a sudden comes up with a cough and a runny nose and says they can't come in for work that day. But we are probably going to have those people do mandatory PTO time. So with regard to starting up our surgical activities, we've done what I think all the points that Brian Cole actually went through in some of the papers that he's produced recently. We've assessed our current COVID situation in our city. When you look at our city, Milwaukee, we're a small Midwest town with about 1 million people in the metropolitan area. We have a positive case doubling time of about 17 days. We've never had a steep curve, and it's now flattening even more. So we have about 245 per 100,000 cases, 100,000 people in Milwaukee County. And just to give you a comparison, compared to Cook County in Chicago, where Bryan is just 90 miles to the south, they have almost double, 447 per 100,000. So, and in addition, the hospital that we work at is more of a small community hospital with less demand on it from a COVID patient point of view. We have 16 ICU beds. Currently, only 9 are occupied, and only 2 of our 8 ventilators are in use. Over the last 3 weeks, we've had a steady decrease in our COVID or patients under investigation population, so that we've gone from a high in April 1 of about 15 down to about 13, then to 10, and we're currently at 8. So I think we've documented that decrease that we need to. We've also assessed our PPE. We feel that we have adequate PPE, including N95 masks for use in the hospital and surgery centers affiliated with our group. Our workforce availability has been assessed, and we feel it's adequate to start cases at about 50% of the average caseload is what we're going to do. We're actually starting, hopefully next week at our orthopedic hospital, 25% of normal, work up to 50% of normal for the 2 weeks after that, and reassess, again, to see how high we can go with regard to the need for the social distancing and the inefficiencies we may see. So our facility is set up to enforce social distancing. Our ortho hospital has been used as an overflow for the regular hospital, but has been a non-COVID floor, so there's been no COVID patients. We have sanitation protocols in place. And with regard to testing, we're certainly behind on that. We don't have the testing capacity that some of the other people have talked about. But again, I agree with the assessment also. The problem is with the number of false positives, false negatives, I'm not sure the testing really does us much good. And we're kind of like, if you're in the situation where we were, if any of you are old enough to have been around when HIV came to town in about 1982, 1983, we're in you treat everybody like they have it. And that's unfortunately where we are. At the orthopedic hospital, we are going to go by the guidelines in that Piedmont protocol, and basically, for the reasons Brian said, start doing what we would call semi-urgent cases. We're only doing ASA 1 and 2, no cases where a sniff is needed. We are certainly limiting to outpatients or anticipated inpatient stay of 1 day, 2 days maximum, certainly with no anticipation of using an ICU. And we're going to attempt to use regional anesthesia rather than general anesthesia and intubation as much as possible and increase that use. And surgery centers are going to be utilized in a similar way. That's where I have it, Louis.
Well, thank you very much, Jim. And Jim alluded to the Piedmont protocol, which is available as a link on the website. It's basically just an algorithm for determining the acute nature of the urgent nature of cases. So, a unifying theme here, but as you can see, there's regional differences that are important. And now we're going to shift down south to Eric Stiefel, who's at Valdosta in Southern Georgia. Eric.
So that's right. I'm in Valdosta, Georgia. It's a rural market. We have a single hospital system, and as of last week, there was 120 positive COVID patients in the county. And for the last 2 weeks, our hospitals showed both a decrease in diagnosis as well as admissions. So we really have a low burden of disease in this rural area. We have up and running now a clinic. It's open half days, Monday through Friday. All of our ancillary services are up and running, PT, MRI, ASC. But we've seen incremental decline in volumes. We did receive our PPP funding as well as our CARE Act payment on April 17th, and this was useful, and I think is going to be very helpful, and we've been able to avoid any layoffs at this time. Governor Kemp lifted the moratorium on elective cases, so we're going to start doing elective cases this week. Actually, the formal date was this Friday. And so we booked cases, 51 cases elective were booked at the hospital. This is lower than their maximum capacity. 19 were booked at the ASC. And there are some differences in the screening protocols at the ASC and at the hospital. At the hospital, the COVID screening occurs 4 days prior to surgery. And I think that can be a debatable point, but that was the decision that we made at the hospital setting. This week, with those screening protocols in place, we had 1 out of 52 scheduled patients test positive, and that was with a PCR test. So the hospital now has 4 weeks of elective surgeries booked out. We have 2 weeks of elective surgeries booked to the ASC. Patients and providers are aware that this timeline may change due to either cancellations due to asymptomatic patients testing positive from screening or potential changes in state mandates. I would note that a lot of patients see this as an ideal time for surgery. So we have had a lot of patients requesting if they could go ahead and book their elective procedures. They see this as a time with a slowed economic pace, the shelter at home. Tier 2, there's less than 40 cases clear our schedules.
Eric, if you could let's switch to Nick and have you're cutting out a little bit, okay?
Okay.
So, Nick, well, we get Eric's mic up. Let's have you step up to the plate here and talk about what's going on in New York, where I believe we have 250,000 COVID cases.
Yeah, thank you. Thank you, Lou, and greetings everyone from New York and Northwell Health. And just to give you some scale in comparison to what Jim Stone said, the disease burden in New York is 1,000 cases per 100,000. So it's a different, absolutely a different situation here. And although we the surge peaked on April 9th, we still have a fair amount of disease, and I'm going to share that with you. So I work with Northwell Health, and Northwell Orthopaedics in New York is a department is spread over 23 hospitals. We have 122 full-time attendings. We have 18 offices. And essentially, we work in a healthcare system that spans the geographic footprint from Manhattan to the Hamptons. And so we are absolutely in the center of the hot zone of this pandemic. And so we have hospitals in Brooklyn and Queens. And as you may know, the disease burden in Queens and Brooklyn and areas of Long Island, in fact, is even.
Nick, I muted.
Hear me now, Lou? So our footprint, yeah, so our footprint is 5,696 beds. And even with that scale, we had to stand up another 1,000 beds and took over the Javits Center in New York City. So the situation here in terms of the disruption of what this has caused in New York is really unprecedented. And obviously our response in terms of the incident response was rapid, and we were all in. And we've done everything that you've heard, as well as scaling back our offices, canceling and postponing elective surgeries. We did maintain all the emergent cases that came through in terms of orthopedics. One thing I will comment in terms of workforce is that 14% of our orthopedic faculty and attendings were redeployed, working in low acuity EDs, actually working on medical floors in the hospital and staffing testing centers. You would not believe that. 40% of our 69 residents were redeployed, including a proning team that was dispatched in Lenox Hill to the ICU. And 82% of our 110 PAs and NPs were redeployed. So we had a workforce redeployment that's only been turned around recently, and that has affected our operations as well. I think the comment that you're going to hear recurrently, particularly in certain hot zones and what hopefully doesn't scale up in other parts of the country, is that the incident response is actually easier than the recovery. I think the recovery is going to be not only more complicated, but obviously, as you're hearing, much more prolonged, particularly in certain areas. Now, what's going on in New York City? We have from Governor Cuomo a mandate at this time against performing any elective cases in certain counties. And they're basing that on not only hospital capacity, but also new cases. And I will say to you, as of today, in those 5,600 beds that I referred to, we still have 2,626 active inpatient COVID patients, and 24% of them are still in the ICU. Well, guess what? Those patients in the ICU who have been intubated now, they're all trached. They couldn't be extubated. So now we're dealing with a cohort of patients in an ICU setting who have trachs. And the ability to care for those patients and to essentially take our hospitals to a whole new level is going to be slowed and is going to take some more time. However, I will tell you, beginning 3 weeks ago, we began a plan and we actively meet daily. I'm involved in a surgical emergency operations center that includes clinical leadership, surgical chairs, and administrative leadership. And we're working on a phased approach to restarting this engine, regardless of how long it takes. And we're looking to do this in a way that's, I think, careful and thoughtful and phased in. And it includes much of what you heard. We have in our system the good fortune of we have 14 ambulatory surgery centers. So of those 14 centers, it will be relatively easy to segregate several of them. They will be COVID-free. We have 23 hospitals. We're going to segregate one in each region, make them and try to maintain a COVID-free environment, and then begin the protocols for adjudicating the database that we've created. What we've done is collected a total of close to 2,000 cases that are level 2, level 3 being urgent and level 2 being semi-urgent. And obviously the emergent cases are getting done now. But of those cases that are urgent and semi-urgent, we've put them into a REDCap database. We've looked at everything from comorbidities to who needs to do those cases, to ASC grades, to actually judging whether they truly need to be done this week or next week. And what we're planning to do is start to do those cases next week. Now, these are not elective, but they are the urgent and semi-urgent. We are looking to stand up all of the practices and procedures with the safety protocols and PPE in place. I will tell you, we have more resources perhaps than in other areas, and we are able to test everyone, and we'll plan to test every patient within 24 hours with a rapid test return who is going to the OR. And although I agree with what Brian and some of the other faculty have said that it may not matter, and we are absolutely employing universal precautions, I think we do want to know in a New York setting who is positive, because we have an obligation to continue to contain the disease burden, and those patients have to be identified if they come in contact with our healthcare workers to be able to initiate contact tracing. We also have a very robust ability to stand up serologic screening, and we're actually screening all of our healthcare employees for a study to understand the issue of antibody production, and then perhaps study whether the antibody production that you see is actually true immunity. And we don't know that we don't have that data, and I don't think anybody does yet. And we have to be certain of that. So we do have the ability to study our large population of healthcare workers who have been exposed. I don't think in terms of our surgical plan that serologic studies are really going to make a difference in this setting compared to acute diagnostic PCR. I will conclude by saying that I think the approach is certainly regional. I think it's certainly going to be individualized, but I do think that there will need to be a massive coordinated effort to restart the program. One of the things we have been looking carefully at is the fear and anxiety that exists, at least in this part of the country, for patients to come back and get their elective cases done. And I think many of my colleagues have presented some very cogent points regarding the reason to get these cases done. But in certain areas, I think until we have more confidence on the part of society to come back to the hospitals, albeit ASCs, I think that it is going to be slow. And I do believe that we're preparing for a ramp up that is going to take us probably 6 months, but we have to start. I think the final comment I will have for everyone is I hope that and believe that what we have seen in New York may not be seen in other parts of the country, but there are lessons to be learned, and there are lessons to be learned regarding preparedness. And although I do hope and pray that this horrific situation is not repeated, if in fact there is a possibility for the risk of resurgence, wherever that may be, I think we need to have learned a lot and be more prepared than we were during the last 6 weeks and perhaps do a better job. So with that said, I thank you, Lou, for leading this, and also will be available for any questions.
Thank you very much, Nick, and please stay safe in New York. So let's see if we can get back to Eric and finish what he's doing down in Valdosta. Eric, are you with us? You're on mute, buddy.
Hey, Lou, can you hear me?
Everybody, unmute there. Let's. Still think we have some. Eric, how you doing now? You still reverberating?
I guess I'm better. I'm back on the computer. Can you hear me?
I think you're reverberating. See if we can fix that. Maybe you try to call in. Nick, I got a question for you. Do you let's go over your definition of urgent versus semi-urgent.
Urgent versus what? Semi-urgent?
Yeah.
So we're using there's a number of stratification guidelines. You mentioned Piedmont. There's a CMS guideline. We actually have used the American College of Surgeons guideline, and unfortunately the numbers are a little bit different. It's not level 4 is essentially open fracture, emergent, tendon rupture, all the cases we have been doing. A level 3, which is considered an urgent case, would be a case that you would like to get done within 4 weeks, and that's arbitrary. It could be several weeks. And if you didn't, then that case would have or lack of doing that case would have an adverse impact on the patient. And an example of that might be, a certain type of problem related to, a proximal humerus fracture, we'll say. In addition, I think you have cases that might require an acute rotator cuff rupture in somebody who has a traumatic rotator cuff. That would be a level 3 case. A level 2 case would be semi-urgent and cases that could be done within 4 weeks to 3 months. So that may be spinal stenosis, and it may be a patient who doesn't have a neurologic deficit but has intractable pain, and you'd like to get them done expeditiously. Level 4 would be out at 6 months. That's the total knee patient who says, you know what, right now I'm not having anything done. I'm going to skip it. I was going to do it in the spring. I'll do it next spring. And so I would like to point out on definitions, and I think in Brian's article, he alluded to this. I don't believe the word elective. If you saw Senator Kerry's article in the Wall Street Journal 3 days ago, the issue of elective is basically that's just because it's scheduled with availability. But the actual symptomatic presentation is certainly not elective if you have pain. So I would like to propose that we don't use the word elective and essentially use the cases that I think are based on the ability of the patient, this should be patient-centric, to tolerate the symptoms. And I think that's an important point to go forward with.
Thanks a lot, Nick. So some questions are coming in, and I don't necessarily need to pick on anybody here, but here's one I'd like to send to Jim Stone. I think he's the most senior amongst us. Does the panel have any suggestions for more senior surgeons returning to the clinical setting, given an increased risk for poor outcomes if the surgeon is exposed?
Yeah, and I can't say really anything specifically. I'm in that group. I'll be honest. I'm 63 years old, so technically I'm at a little bit increased risk compared to you younger guys. I think that every surgeon has to assess their own health status and be conscious of that and make a personal decision. I mean, I guess in my own case, I feel like I'm in pretty good health, a couple of minor, well-controlled medical issues, and I figure I'm not too different, so I'm going to go back to work as I can. I think that certainly if you've had cancer in the past, if you're on immunosuppressive drugs, things like that, I think you have to be really careful about how you consider going back to work and weigh those risks and benefits. But I think it's totally a personal choice.
It's interesting, and Nick, you may want to comment on this, but at Rush, with the precautions we're discussing, when working with known COVID positive patients, the incidence of healthcare workers becoming infected is incredibly low. So, Jim, your concerns, we all share concerns because none of us want to be infected, but obviously the differentiators.
You're probably more at risk from the person you don't know has COVID.
I'll share with you, Brian. I'll share with you some data. We just actually submitted this to JBJS. Hopefully they'll take it, and it is our incidence of healthcare worker conversion, frontline workers, was 4.4%, which is basically unbelievably good. If you look at the Wuhan data, the incidence of healthcare worker conversion was 22%. So we attribute that, at least at our hospital, to we put into place safety monitors. We had a compliance program. We had appropriate PPE. We had all kinds of precautions. And I will share with you, a number of my partners were redeployed to the front line, and they were getting exposed. So I do believe that you can contain the disease. And I do believe there's a risk, but what I'm worried about, and I think what maybe Lou said, is I do think that if you have comorbidities, there's an article in today's JAMA, the lead article in JAMA is from our institution, which says just about everyone who died, 70% mortality on the vent patients, had at least one comorbidity. So this is, I think, the issue here. Now, everyone probably has something, but the point I'm trying to make is, I think in my older partners who might have something, I didn't redeploy them, and I had criteria for not redeploying certain ages, and I'm going to say, take your time coming back.
Thanks, Nick. So we have a couple of questions about testing. So Brian, if you go over the two tests that we have, their relative sensitivity and specificity, and if you can't get a test, do you need to get a chest X-ray on an asymptomatic patient?
So to my knowledge, chest X-ray has not come into play as far as a screening tool. So what's really interesting is that, so first of all, we, without going into the different mechanisms of the test, PCR, serum, other, we have a test for COVID positive or negative, and we have a test for IgM, IgG, recent or delayed infection. And the big challenge that we have is that determining if you're COVID positive or negative is when we do those, whether it's sputum, nasopharynx, or brain thing, right? All three of those exist. If you guys have had this test, if negative, you may still have the virus. You may still have the virus, yet you don't. Sorry. I actually think that's my son. If negative, he won't take no for an answer. If negative, 2 days later, you could become positive, not having been exposed to someone else because you're just not shedding enough virus. So the challenge is, so the other issue is, as you're alluding to, is sensitivity, specificity, accuracy, and so forth. And all of that changes based upon disease prevalence. And this is only about a 2 to 3% prevalent disease right now in the United States, even though we think it's everywhere. So the other bigger problem is this serum test, because people think, well, I'm positive, so I'm good to go. I got IgG. The big challenge is that's where prevalence really impacts the nature of the test. And if you are negative on a serum test, looking for IgM, IgG, supposedly you have not been exposed to the disease. But if you're positive, there's up to a 30% false positive rate. So the challenge there is that you may be behaving differently when there's really no biological reason you should be doing so. So I think the challenge, we're all talking about test availability. We're in the middle of writing a whole review on what's in and outside the FDA purview. In other words, what's been FDA approved and what is not. I would caution you. I'm getting emails from these companies, from these groups that say, look, I have access to these tests, $150 for this, $200 for this, and you'll know in 24 to 48 hours. I would caution you that the big problem the FDA is seeing is that there is a huge amount of problematic sensitivity, specificity, accuracy issues with many of these tests. We did the Stanford test recently. It's not FDA approved. We did it with 10,000 people through the MLB. And we were surrounded by people who we knew were positive, did not show IgM or IgG on a finger prick test. So the FDA issue, this is one where you want the FDA to be involved, and it's a little bit of a moving target. But the bottom line is, I would argue that I'm not sure we're at a point where anyone should change their behavior if you're positive on the COVID test or if you're positive on the blood assay for IgG, IgM. The one thing that we are changing when we get a positive COVID test, I'll just tell you, this is the one thing we do different. If someone comes in and we know they're COVID negative, then when we intubate, very rarely, people will very rarely cough upon intubation. So we allow draping and prepping of the extremity after intubation as long as there's no coughing. That's in the setting of with or without a point of care testing. If you have point of care testing and they cough when they're waking up, some places of what they're doing, they're still arguing that you can come in and clean the room. I'm not sure that's responsible or not, but that's they're using it for efficiency purposes. But in the absence of COVID testing at point of care, people are generally waiting 15 minutes before they clean the room. That's the only area I can tell you that we're using the test. We're treating everyone else as if they're COVID positive with universal precautions.
So you're comfortable with universal precautions and surrogate screening?
Yes. One final point. I don't know if I said it, but we tested 300 people pre-surgically. We had one positive test. When we re-questioned that person, they said, I actually think I had a fever yesterday. I wasn't sure. I have been coughing. He basically wasn't truthful on it. The fever, testing for fever is one of the most sensitive and specific things to do. So when they are asymptomatic, the likelihood of them shedding virus is still very, very low. So the best we can do is with the things we've been doing. And that's why I think social distancing is going to be sticking with us, because that's the one thing we know. 6 feet, wear a mask, and all the hygiene things. That's the best thing we can do, short of a perfect test or a vaccination. At least, look, none of us are experts in this area, but these are the things that I'm gathering from our command center calls, speaking with our ID folks. And again, Nick, you're in the trenches here. If you think some of the things I'm saying, you have difference of opinion or you're exposed to different information, please share it. This is very
I totally agree with you. I'll just add 3 things. One, and some of the questions coming in from Mexico in using chest CT as a screening, I don't have any experience with that, but pulse oximetry in the absence of testing has some value. Again, this is not scientific and we don't have data fully on that, but there are some patients, if they're not oxygenating, they may have the point of the test. Second is, we have a cohort of labor and delivery patients, all of who were tested, asymptomatic, no to low morbidities, no symptoms at all at the end of their delivery time. And we had in that group a 22% incidence of positive testing. Now, there are more false negatives, but the PCR test has a very low false positive test. So keep that in mind in terms of the asymptomatic carrier. We don't know about asymptomatic shedding as much as we know about asymptomatic carriers. And then the last point is, I agree with you, Brian. I think right now, everything that you've written and that you've mentioned, we are employing as well relative to what I would term universal precautions. The problem we have, and you have to think about, is that in a high disease burden hot zone, there will be patients that come through and then may infect your staff in your PACU. And so we do want to test everyone for that reason, if no other. I think your providers in the operating room, you're going to be taking all precautions, but I think you're going to need to also think about your PACU.
Nick, do you have any data regarding post-op COVID infections at all, or any information about that?
Yeah, so we have some information in terms of, this is anecdotal level 7. We have 4 cardiac cases that got done, and of course, by definition, have some comorbidities that were COVID negative, came in, were done in the COVID positive hospital, but segregated, and then converted. And in that group, 40% ended up on an ICU, 20% mortality. The point being that at least in the cardiac group, and this came out of China as well, and some of the higher catabolic procedure group patients, that their ability to recover from those types of surgeries was significantly impacted. That's going to affect certain cases in the elective group. And I think we have to be concerned about that. Relative to infection in the COVID group, we haven't seen any change in that group, in the patients that don't have organ failure. Obviously, with the organ failure group, that's the issue, but we haven't seen it in the patients that we get in and out. We have about, I think it's 290 ortho cases that were emergent. Those are your hip fractures, et cetera. And as long as we isolated that cohort and got them out, we didn't see an increased risk of surgical site infection in that group.
Thanks, Nick. That's great. So, Jim, do you think the ambulatory surgery center should be able to offer elective surgery before the hospital if there's not a surge in that hospital's patients volume of COVID and they have PPE available?
The short answer is yeah. I think that's the perfect setting to start doing elective surgery, or not. I call them non-urgent surgeries. Again, I think it all depends upon your environment. Again, we're a pretty low penetration of COVID in ours, so I don't think it makes much difference in our community hospital, our hospital versus our surgery center. But certainly, in areas with higher COVID penetration, the surgery centers would be a much more likely place that you could keep as a non-COVID institution.
Thanks, Jim. Eric, we'll try one more time. Are you with us?
Can you hear me, Lou?
That's great. What might you add to all that that you're doing down there that might help our membership and our viewership here?
Well, I agree with Jim. I think the ASC can be an ideal place to proceed with surgeries. There has been a significant demand from patients to have elective procedures. At the end of the day, this is still a shared decision-making process where we discuss with patients the pros and the cons of both non-operative and surgical treatment. And if the resources are available, if the PPP is available, if the state restrictions have been lifted, then I think allowing a patient to proceed in what their desired direction is with a surgical intervention is perfectly appropriate, especially when you look at the measured risk of exposure at an ASC versus in everyday life. I don't know that there's any data that shows us that having a surgical intervention increases the risk of a COVID infection.
And finally, Eric, are you with a potential backlog of cases? Are you anticipating running your surgery center on the weekends or at nights?
So we are running Saturdays. So we've got this first Saturday booked, and we're going to see how it goes from there. We had anticipated a little bit more of a backlog than we actually got. I do think a lot of the individuals spoke to a little more hesitancy in a desire for patients to have elective procedures, or for that matter, even go to their doctors. So we are doing this Saturday. We're not planning on doing next Saturday, and we'll just see how it goes from there. We're going to see how quickly we can get through the log. We've got 3 weeks of scheduled AFC cases at this time.
Thanks a lot, Eric. So there's a question about the session and the future. Is it being recorded? Yes, it's being recorded, and it's going to be on the web, and you're going to get an email link that's going to direct you to the web. And with that link are going to be all the other documents that go along with this, such as the Piedmont Protocol and Eric's Brian's articles. Finally, this is the best question that we've gotten, because it gets back to the point that we want everyone to return back to a normal life. So the big question now is, who's going number 1 in the NFL draft, and who wants to take that?
Go Jets.
Yeah.
Burrows.
All right.
Burrows, LSU.
One more question here. From Arkansas, opening for elective cases include testing within 48 hours. However, only one of our hospitals has the capability to do this. They will not provide testing for any ASC. This includes ophthalmology and ortho. What are the panel's thoughts? My thought would be, do your surrogate testing, right? Your temperature, you segregate the patient on the age, the ASA level, symptoms, temperature, etc. Any other thoughts?
No, I think that's it. I don't think that, as I said, because availability will vary around the country, I don't actually think that makes it any more or less safe, because when you take proper precautions, the disease transmission rate is very, very low. Assume everyone's positive. So I think it would not be right to burden the system further by using that as a stopgap, given the variability in testing availability.
I agree, and I would just add, I would start slowly, and I would cherry pick the case, obviously. I mean, so that's another way to do it.
I agree, Lou.
I think that's key. I think what we're seeing, look, you're safer to go to a surgery center where you have a patient questionnaire, temperature check, check their SaO2, than you are going to the grocery store, right? Where the guy next to you could, he's not getting a questionnaire, he's not getting temperature checks. We are in is probably the best controlled environment that we have, provided we're using our medical knowledge and we're doing the best thing that we can do.
Great. And I think with that, everyone said the same thing: safety. So let's all be safe. Let's all think with our universal precaution hat on. Let's take care of ourselves, our patients, and our staff. And I would pray that we get back to something that approaches normal fairly quickly. Orthopedic surgeons are the best problem solvers I've ever known. And I know that we're going to get through this, and we'll emerge on the other side and get back to being not just surviving, but thriving. I'd like to thank the panelists. I'd like to thank the staff. And thank you, everyone, and have a great night, and be safe and healthy. Good night.
Thank you. Good luck, everyone.
And thank you, Lou, for leading our discussion. I think it was a great, well done. So I appreciate you moderating us. Thank you.
Thank you.
Thanks, everybody.
All right, bye.